now my pleasure to introduce our new dean, Maureen Lichtveld, who just started in the position January 1st. I think today is the 22nd, so it's 3 weeks. So we're really excited that she has taken the time to join us this afternoon. She joined us from Tulane, where she was director of the Center for Gulf Coast Environmental Health Research, Leadership, and Strategic Initiatives, professor and recently chair of the Department of Global Environmental Sciences. Her research focuses on environmentally induced disease, health disparities, environmental health policy, disaster preparedness, public health systems, and community resilience. And we're so thrilled that she is now here at Pitt Public Health to oversee the growth and continued success of our school. So welcome, Dean Lichtveld.
Good afternoon. I'm so excited to be with you. Earlier on, I told Associate Dean Burke that this is my foremost wishes to be very quickly, very closely connected to our students, and our students are, to me, our highest priority product and our greatest stakeholders. And so what Dr. Burke asked me to do is kind of talk a bit about my career, how it came to be, focus some on my research, and talk about the future of public health. But most of all, I'm just going to be greedy and want to spend as much time as possible with you and answering your questions. So I will take you from the Amazon rainforest indeed to here, to Allegheny County. What I'd like to do today is a bit of an introduction about myself, talk about some career highlights, introduce my vision for the school, specifically mention strategic imperatives and priorities. And as I already told you, I just want to get to know you. And I wish we could actually have done this in real time and in person. And so a pinnacle in every scientist's career is to become a member of the National Academy of Medicine. And that's the first picture that you see. My area really of commitment is, in addition to research, and as you heard Dr. Burke mention, is transdisciplinary in design, focuses very heavily on disparities and disasters. And yes, the COVID-19 pandemic is a disaster. I'm very keen on building infrastructure capacity, not only in the school, but also in our community, and I'll come back to that. My style, and that was one of the questions that I was asked when I was interviewing here, is what kind of leadership style that I have, is very much collaborative. And yes, we're already involved in strategic planning. And I'll say a little bit more about fundraising, because one of my priorities is to name the school. Partnerships are key, not only with communities, but also with other schools within the health sciences. And yes, with policymakers. I'm very pleased that our Secretary of Health will now become the Assistant Secretary of Health for our nation, Dr. Levine. And personally, I'm married, I'm a mom, but I also am so happy to be a Mimi of 3 little ones, a 3-year-old, a 2-year-old, and a 5-month-old. And so that's where I hope to spend a lot of my time, because they live over the weekends, because they live about 3 hours from here. Okay, so we're a Suriname. Usually when I start these kind of conversations, I'm in person, and I challenge people to actually tell me where my accent is from, because you clearly hear one, or where I am from. And people usually put me in Sumatra or some kind of Asian country. Yes, I am part Asian, but I'm actually from the Caribbean. And so if you follow that red dot, I am in Suriname. We'll go back. That's where I'm from. If you follow the red dot all the way over, coming to the US. So it was former Dutch Guyana, and it's part of the Caribbean, and the north, so a little bit closer. The northern border is the Atlantic Ocean, the southern border, Brazil, the eastern border French Guiana and the western border Guyana. Lots of oil currently and bauxite, but also with that come lots of contamination. It's a closer look at the country, and I will take you to some parts of the country on the coastal side, but also in the interior where most of my research is currently going on. I take students to, if you see that blue lake there, I take students to that blue lake. And you know, if I am well established and I have time left in the summer, I would love to take Pittsburgh students to Suriname and to do both research and to learn. So here we go. This is me at 6 months. My nickname, or I think it's nickname, was Little Dove. And so I didn't turn out to be so little, but so here's where the journey starts. Believe it or not, I once had black hair. And was several sizes smaller. This is my graduation ceremony as a physician at 23. And I have gone back and now actually have taught many students in Suriname and students from Tulane in this very classroom. And so you could see below where my hands are, it says niet roken, meaning, and it says no smoking. So even back then, there was an emphasis on stopping to smoke. So my voyage, my maiden voyage into public health was by dugout, when in 1979, I began to practice in Suriname. It's very much like the Netherlands. It's an 8-year degree program to become a physician. And so in my last year, I began to practice and asked deliberately to practice in the interior rather than staying in the city, because I felt that that's where I could be of service to vulnerable populations. So my call to address health disparities and provide services to vulnerable populations came from then even. You'd see me in a motorized boat. No, so we went from a wooden dugout to kind of a motorized with the outboard motor given by a Chinese local organization to me when I practiced. And the nun and the woman that you see on the shore were my first community health workers. And so I worked very closely with them to improve the vaccination rate. And it's actually remarkable that we still talk about immunization and vaccinations. That I took over there, the childhood vaccination rate was about 5%, and that I got into in 3 years to 95%. But I couldn't have done it without community health workers along the way, along the villages. This is also the river my kids know where if I move on to the next part of life, that they spread my ashes in. So it's called the Katika River. But really, my aha in public health came from this market. This is a farmer's market in the little city, the little town that I worked in called Mungo on the eastern border. Because anything I did, any patient I took care of, any food handler work that I did, any deliveries that I did, whether it was in people or in animals, any foodborne illnesses I addressed had something to do with the environment. So not only was it my public health aha moment, but it was my aha moment to devote my career to environmental health sciences. And I hope many of you will do the same. Following my specialization at Johns Hopkins, I spent 20 years at the Federal Centers for Disease Control and Agency for Toxic Substances, where I fulfilled several leadership positions and was able to address nationally the impact of environmental exposures to health disparate communities. And so one of the seminal policy act, and that's why my interest and my expertise in environmental policy is developing the science behind policy so that we can get actions on a public health on the public health front line that are science driven, and we're very pleased to be able to do that again in our country. So one of the cases early on, and so as I tell my story and my research, I'll share specific cases. On a Friday afternoon, and those things somehow happen always on a Friday afternoon, we had a call from the health director in Mississippi saying that there were people who were having some kind of strange flu set of symptoms. They were short of breath, but then they developed headaches, but it didn't quite look like the flu. And so we went and investigated, and when it turned out that actually this was a repeated concern. What had happened is in a public housing area, there were 2 unlicensed pesticide applicators who decided to do something good. And what they decided to do is to use methylparathion that you see on the left, that is used as a killer of beetles on cotton crop. You know, in the South, there's a lot of cotton. To provide that to homeowners and to spray the homeowners' houses. But they sprayed everything. They sprayed children's cribs, they sprayed ovens, they sprayed attics, they sprayed rugs, they sprayed, couches. And they also guaranteed their work. And so if the cockroaches came back, they actually left the homeowner with either a milk jug or some other jug of undiluted methylparathion. And so remind you, methylparathion, the half-life of methylparathion, so the amount of time where 50% of the concentration would be gone in the outdoors, is about 48 hours. And the inside, it could be days to months. And so children crawling, children sleeping in their crib could be exposed for a long time. And so what we did is, for the first time, we actually let our risk management effort and our public health intervention be guided and directed by protecting those that were most vulnerable. And so you could see on the left-hand side that we really prioritized the very infant, 0 to 1 year, and then the young adults, and then the adults. And so we've been able to do that, not only protecting them, but also saving money rather than saying everybody has to leave. Kind of one interesting, anecdote here is that we had to relocate many people in the public housing and didn't have enough space to do that immediately. And so in that little city where that was happening in the town, the Barnum and Bailey Circus was visiting. And so we collaborated with the circus to provide us some of their trailers to house some of the people. And so it is a testament to public-private partnership where public health can get into action. And so from graduating at 23 to going back for the first time in 2008, and then in 2009, I was invited to be the commencement speaker for the university, and particularly for the Faculty of Medical Sciences, something that was personally very special to me. I went back where at least one part of my ancestors came from, in Guangdong province in the south of China, and was able to be the inaugural, provide the inaugural address to a new MPH program. And so that was, the anecdote, there's so many anecdotes that I could share with you, but one of the anecdotes was that I do not speak Cantonese. And so just like Jesse and I did earlier, I practiced so hard to be able to say, little Dove is back home. But because of my accent and my focus on specific falls, it came out as the hole in the wall is back home. And so everybody was polite and kind of applauded politely. And later my colleague said, Maureen, this is what you really said. And so I stopped practicing Cantonese after that. Okay, now to Louisiana. As Dr. Burke mentioned, I put in place a Center for Gulf Coast Environmental Health Research, Leadership, and Strategic Planning. You could see that community engagement was key to all that we did, as was anthropology. So often we emphasize only the analytical sciences, but here that integrated whole person, whole community approach is what is so critical. And so through the center, we address the largest oil spill in the world, the Gulf of Mexico oil spill in 2010, where 2 million gallons of dispersants were dispersed to get the oil out, but 4 million barrels of oil was spilled because of that fire that happened on the rig. And so one of the things that we did, so I led an environmental epidemiological cohort and a consortium that was funded by NIEHS, but I didn't do it the way typical research is happening, or a lot of research is happening, and I'm hoping that that kind of research is not happening here, where we sit in isolation and don't work with the community and do research to the community. And so I went to our community, and particularly to our Vietnamese community who have suffered so hard not being able to go fishing, and said, what is it that you're concerned about? And they said, we're concerned about 3 things. Can we eat the seafood? Is the seafood safe to eat? Is the air safe to breathe? And what will happen to our babies? The women who are currently pregnant during the spill, what will happen to the babies who are born? And so we took that triad of community concerns and developed a full consortium around that. And so we went shrimping. This is one of our master students to the left, but we went shrimping with Vietnamese leaders, as you could see to the right and inside. Somehow they didn't allow me to go shrimping because perhaps they didn't think I could stay up all night. But one of the things that we did is we did not, as many other groups, we did not only analyze the fish that were caught and the shrimp that were caught on the market. What we specifically analyzed was the leftover extra that the community consumed. And so we knew that what was left over in the fishing nets is what they consumed. And that's what we tested to make sure that we knew what their risks were. And we could not, and here is where science has to be driven what community needs are. We could not use the standard Environmental Protection Agency or Food and Drug Administration calculation for risk, because we don't, in New Orleans, particularly the Vietnamese community and others, don't eat 4 shrimp, they eat 2 pounds of shrimp. And so to calculate, and they are not, 6 foot and, 180 pounds, they are 5 foot and 68 pounds. And so that all matters to what the risks are. And so we're able to publish that and demonstrate that when the communities inform your research and your science, you actually get the right data out and be able to intervene and help. What we also did is, as part of the medical settlement, and there was a lot of concern and actually animosity, of course, against BP, the judge freed up $105 million to build public health capacity. And I was approached to help design how we would do that. And it resulted in the Gulf Region Health Outreach Program. So not necessarily research here, but capacity building, but we had several publications out there. And one of the things that I'm most proud of, and what is now considered the jewel of this program, is in that case, an environmental health science academy where we worked with juniors and seniors in high school to bring them into Tulane, but also have them advance to a college career. We've been able to have college admission in 92% of those who applied, and we'll do the same thing here in Pittsburgh. So let me then take you back to Suriname, where we started. This is another large environmental epidemiological consortium in the Caribbean. And this is also the journey that students take with me. This is the Amazon rainforest in the back. And this is how much was cleared within 90 minutes. So it takes us 90 minutes to walk into the rainforest and come back when we do the site visit. And when we came back, this is how much was gone. And it is because of looking for gold. This is gold mining. And so to the left, you see where they use water blasting as a way to soften up the mud. They then add mercury to it and take the gold out. What's left in the rainforest are these large ponds that you see the color of the water. The color of the water is bluish, grayish, greenish. That's mercury-laden water, mercury-contaminated water. So when they take that the mud that is now softened, they add it to this somewhat primitive device on the left called the sluice box. That's where they then mix the mercury with the mud and retrieve the gold. What is also then happening is the mercury is not retrieved. The gold is, but the mercury is not, and it goes into the surface water and the drinking water of the communities that live in the interior. To the right, and if we had interaction, I would ask you what fish there is, but I'm hoping that many of you know that this is a piranha. And the piranha is the most loved fish to be consumed in the interior. I mean, I made piranha soup for years and years. But the piranha is also the highly contaminated with mercury. So very quickly, I know that not all of you are in environmental health sciences, but I can explain what happens. So when mercury is then released into the surface water, into the rivers, it attaches primarily to the bottom sediment, and little plankton eat the kind of, it's accumulated in there, and then the little fish eat the plankton, and the big fish eat the little fish, and humans eat the big fish. So that's the food chain. So we designed an environmental epidemiological study that focused on exposure assessment, looking where the exposure is coming from, focusing on diet and environmental and occupational, and then looking at birth outcomes in pregnant women and neurodevelopmental outcomes in the baby. And also looked at how medicinal plants sometimes can help address those neurological, adverse neurological consequences. There was a research component to it and a major dissemination and community outreach component. So this is the map again of the country. This shows you the 7 study areas, but really 10 study sites, 1,200 people, and in many cases in the interior, including where I practice, you could not even go by car. You cannot go by car. You either have to fly and then go by boat. And so sometimes it took us days to get there. And so how do you keep blood and umbilical cord specimens safe during that time? And so what we did is we bought refrigerators for them with little freezers with energy from solar panels. And then we had kind of a few days a week, there would be a flight that would go in, a little Cessna with 2 to 4 people, then we picked up the biospecimens. So this is what we found. So 3 major study areas: the Paramaribo's the capital, Nickeries in the west, and the interior is really the Amazon rainforest. that dotted line you see is where the U.S. Environmental Protection Agency said anything above that is of significant health concern. You see where the levels are in the people, in the women in the interior. You don't need to have a significant, a major calculation to figure this out, right? Here I am having to speed learn again, and not only freshen up my Dutch, but learn the native language again, and all the tribal languages from when I used to practice. But talking about in Dutch here in a press conference in a local community about what we found and what we should do in terms of dietary exposure, particularly in pregnant women. So if we were not enough, it wasn't enough to be concerned about mercury, we also found lead. And again, you see the US EPA action level, and you see how much elevated we found in blood in the women, the pregnant women in the interior. Now, where is the lead coming from? It's not coming from the gold practices per se, but where it's coming from is there are metal plates like where you make pizza on, kind of, that they use to make cassava bread, so yuca bread. And that's where the lead, we thinking, is coming from. Another major source of lead is in the old days from old industry where lead is still in soil, and where pregnant women eat, it's called pemba, eat some of that soil to get more minerals out during pregnancy. And that's another source of lead exposure. Pesticide is the other thing. I need to make sure I keep track of time here. Pesticide is the other exposure that we looked for, particularly in the western part. You see the import of pesticides. The only thing that's regulated in terms of policy is the import, but not the distribution. And so you could send a child to the grocery store at the service station, and they could buy, a gallon of X pesticide and a loaf of bread. Nothing is regulated. And so this is what there are policies now finally coming in place based on the data that we provided to the government. But it's the picture that you see. To the left, you see the three pictures. The left picture shows you the crop spraying of pesticides. And sometimes these crop dusters also go over schools. And we have kids who are fainting and schools who needed to close because these are all organophosphates, and they affect muscles, the nerves in many muscles. Roundup is something that we know over here as well. Let me go back. And then mosquito coil. We analyzed mosquito coils because here's a challenge. Suriname and many countries in the Caribbean region go through endemic times and peaks of dengue and Zika. And so to get rid of the mosquitoes, many people use mosquito coils in their homes. As a child, there was always a mosquito coil under my bed and in my room because no mosquito could, touch me as the only child. And so we analyzed when 500,000 mosquito coils were imported to deal with Zika, we analyzed the mosquito coil, and this is what we found here in the US. Mosquito coils that were imported from China to Suriname. One, the concentration of the pesticide that's supposed to be in there was much lower than what the label said. And second, the mosquito coil was contaminated with a number of other chemicals, including lead. And so people were not being protected and being exposed. And so you could see that personal protective equipment is not quite there. You could see mosquito pesticide spraying where kids are also kind of taking a shower in the same irrigation, and you could see the piping there of sewage treatment. My belief and my commitment to communities and creating partners as community leaders is global. And so here you see community health workers all graduating from the 80-hour competency-driven community course, and they currently are the leaders in helping us address the pesticide issue. Here is initial data of one of my students just graduated with her PhD, where you see indeed in that area, in the western part of the country, we have a lot more. This is an herbicide, 2,4-D. We have a lot more of 2,4-D we found in the urine of pregnant women living in that area versus the other two regions. We also found, when we analyzed some vegetables, banned pesticides, pesticides that were banned, such as endosulfan and lindane, since the 1970s in developed countries. And so how the pesticides got there and are still being used is not only a question, it's almost unethical. Okay, so as part of that research training, we also spent, as part of the research consortium, we also put significant emphasis on capacity building in environmental health, both with short and medium-term training, but also at the end of this summer, 9 Surinamese physicians and other health professionals will actually graduate from this program with their PhD. And I'm very proud of that, to create that cadre. So here are some of them presenting at conferences. This is, I want to particularly point out the lower right corner, Ari. Ari is a Native American who will graduate with his PhD. I'm so proud. This is the first environmental health PhD environmental health scientist trained at Tulane, but living in Suriname and currently a postdoc on many of my research projects, Dr. Abdulwahid. And my work and training also involves the entire Caribbean. These are environmental health professionals where we do annual environmental health research training through the Caribbean Public Health Agency. So I'm taking you back to Suriname very quickly before we open up. This is the beautiful historic monument, the presidential palace, all in wood. To the right is a symbol of religious tolerance. A mosque is right next to a synagogue and right next to a church. They share the same parking lot, and that should be possible. Some of you might have read in the New York Times about this unique bird competition. And so it's happening, that bird competition is happening along this, this shore. Students visit, and we work very closely with the Ministry of Health to the left and the Pan American Health Organization. Lots of great fruit and fruit. The students that I take with me, so this is particularly for the students, I take students with me, I've done it now, 5-6 years, every summer, 3 weeks, and we go into the interior, by dugout. You see in the middle is the most important and interesting visit. This is Uncle Fritz. Uncle Fritz is a medicine man. He has a 6th grade education, but he knows every single leaf and plant by their Latin name. And so having done 6 years of Latin, I was really enthralled. This is to the upper right is where students, we travel through, indeed, deep into the rainforest. We take students to the U.S. Embassy, and the U.S. ambassador invites us to celebrate the 4th of July with them. So they are in Suriname, but still get hamburgers and hot dogs. We, as part of the gold mining, the habitat of sloths is impacted. And so students get involved with feeding the sloths. They also have the bottle, yes, and taking care of the sloths until they can be released back into the Amazon rainforest, and they like hibiscus. We assess and look at the habitat of pink belly dolphins that you see here, because they're the dolphins that are unique for where they're coming in the coast of Suriname, and in the coast of and in Brazil, but their habitat is being contaminated by garbage. This is one of the groups. This is where we go and see a reservoir where there is saltwater intrusion. But the idea is to preserve that reservoir for flamingos, and part of the trip is actually literally pulling the dugout up and down this kind of bridge. And so everybody's at work here. Very unique plants and animals in our nature park there, Brownsville. To the right is a frog that has, as its Latin name, Surinamensis, is specifically or first found in Suriname. And this is the pinnacle of the study abroad, where we actually spent a whole weekend with Uncle Fritz in this village on Tonka Island, and where we walk into the rainforest and learn from him the specific plants and the medicinal purposes and qualities of those plants. So this is how we wake up every morning. I get a lot darker when I am in Suriname, and what I'm holding in my hand is the bark of a tree that is made into a cup and that has antipyretic qualities. And so if you put hot water in it and drink it as a tea, it will lower your temperature so it is against fever. And to the right is the most frequently consumed vegetable, and that was the most highly contaminated. You give it to kids, people give it to kids there when they are 4 months old, and it's the most highly contaminated currently with some of the banned pesticides. You could be there too, and I will try to think about, if I have a spare time, how to take Pitt students with me. The students do their practicum there, the 200-hour practicum, and several PhD dissertations are coming out of the country. And so medical students could do their community rotation there. And actually, there are even married couples that have come out of these trips. So. Okay, now back to us, back to now in Allegheny County, before I open it up. As part of my vision for the school, I've developed, and we're very busy on implementing with leaders in the school like Dr. Burke, 4 strategic imperatives. The first one is get us back where we belong. It's in the top 10 ranking of schools of public health in our country through doing more transdisciplinary research, the research that I shared with you. Diversifying our education and enterprise, and I am so excited that we're making progress on implementing and putting in place a Bachelor's of Science in Public Health program. Now, why would you say I'm a master's student, or a PhD student? Why does it matter to you? It matters because we will very much be looking for you to be teaching assistants in some of our courses and be leaders for some of those capstone. And so be thinking about that if you're interested in that. We'll be starting this fall. We're very keen on working closer with the University of Pittsburgh Medical Center, particularly with the health plan. And we're absolutely very, very, very focused on naming the school. So as I shared with our team of faculty and staff, I'm looking for a rich aunt or uncle. So give us a hint if you know one. And lastly, some of the priorities coming out is precision population health, where we focus very precisely on community health problems to tailor our research and tailor our education and our practice. I've talked about the BSPH program. There will also be working on a new MD-MPH program or a revised MD-MPH program. The focus on diversity, equity, inclusion is key for me. It's my life words of focus. And I hope to learn from you how we do a better job there. Very focused on climate and health, including and encompassing overall global health, working very closely with our health departments to learn from them and for us to help them. And so the notion of an academic health department, making sure that each of us, faculty, students, and staff, are in our communities doing service for the community. That's part of what public health is all about. So our footprint in the community. And lastly, to be even more well-known than we already are, by thinking about, and students sometimes have the best ideas because you're so intellectually involved and you're so much more knowledgeable about social media and all that. But we're actually, and I'm not sure whether this would be a contest or something, but we're very interested in renaming some of our departments to make it clearer of what the department does and is about. So if you have ideas, please let me know. And so I'll leave you with the sun rising on our school, on our community, on our partnerships here in Allegheny County, and saying to you, thank you in the local Surinamese language, so Grand Tangi. Thank you.
Thank you so much. It was great to learn more about your background and work, and know that I love the focus on community engaged work and research and practice and capacity development. And I will just say that I learned a lot about environmental health sciences too. And I definitely would like to sign up for that trip to Suriname if it becomes a possibility in the future. So let's collaborate. But I know that other people want to also talk, so I want to open it up for discussion. The chat is really the most straightforward way, and what I'll do is go through some that have already been posted and invite others to add their questions and comments. And if you want to ask something through video too, please just put a note in the chat and we can make sure to call on you. So there is a question here that came up early on when you were presenting about, given that we have the first Native American woman as a Secretary of the Department of Interior here in the US, does that give you hope for public health research pertaining to places like the Amazon River, and whether or not that will improve in the future? Could you comment on that?
Yes, we have a great way to go. I currently have a grant in Louisiana with the United Homa Nation. It's a state-recognized tribe. And the reason for the grant is not so much environmental. The reason for the grant is that they are the first refugees that related to climate. And so their land is flooded. And one day they had no land. And so what we're looking at is the impact on their culture, the impact on resilience, on community resilience in that community. The Indian Health Service, and I've worked when I was at CDC with all federally recognized tribes. And in fact, one of my studies in New York, where we looked at PCBs, polychlorinated biphenyls, exposure in pregnant women. And so we looked at it in breast milk. That nation, and rightfully so, said, you federal government, you're not coming onto our land and studying our people unless, one, we review your study protocol, two, you make us partners, and three, you actually pay us to be part of your study. And so we did all three, and there's so much that we've learned way back then when I was a rookie medical toxicologist. I have great hope, and I'm so proud that we have a Native American in a place where we have the most opportunity to make a difference.
So there are a couple questions that are coming up in here about your background and dedication to international and global collaboration. And can we expect Pitt to develop similar relationships around the world? So maybe the comment here specifically asks about East Africa, but maybe we could broaden it to sort of global health within the school and your vision for that.
Yeah, I was actually somewhat surprised when I came here to school and didn't see such a great focus on global health, because whether it's Africa or Asia or the Caribbean and Latin America, it's vital that increasingly, and we thought that was not the case in the past, and perhaps people still think that, but increasingly we learn from lower and middle income countries how things need to be done in our country. So it's reverse technology transfer. I am just, not a couple of days ago, we talked about Hanoi and a collaboration with the School of Public Health in Hanoi. I can't wait at Tulane, we had an affiliate in Rwanda, and so worked very closely there, and in the DRC. So I can't wait to get us focused more on public health, on global health within public health, but also to now, given the new priority finally on climate and health and the climate crisis, to focus on that. For example, Saharan dust not only impacts people in Africa, our communities in Africa, but it impacts our communities in the Caribbean. That's how far it goes. And so if we don't address the impact of climate on our communities, we will not be able to address that individual, allergy or asthma, because we're not addressing the root causes. And so I am so excited to strengthen our global health expertise and our global health opportunities for our students. Yes, we want you to be in the field after you graduate, but we want you to learn globally before you do that.
That's great, thank you. So another question here is about, as a fellow South American with roots in the Amazon, I'm very excited about all the priorities you've mentioned, and they thank you. Will you have a greater focus on Indigenous health? So that's one question. And then the second is about whether or not you'll bring back the certificate related to disaster management.
Let me start with the last one. I am so excited that there's even a certificate. And actually, I'd like to bring a full program here. It's a program I started. When September 11 hit, I was in the bunker at CDC. I started the program in disaster management at Tulane. It is now one of the most popular programs. I have graduates in the Department of Health and Human Services, in Department of Health Security. I have people in Bangladesh. So I'd love to bring that back up, because as I mentioned, climate is a disaster, COVID is a disaster. So we don't have to think only about natural disasters as disasters. With respect to Indigenous health, there is so much we need to learn, but above all, so much we need to do to gain trust after the history of neglect, of racism, of abuse, of killings. And so there's so much we can learn from our Native and Indigenous people, that it's time for us to do more. But above all, it's time for us to learn, and learn in a respectful way.
So what I love about these discussions is that we cover a broad range of topics, right? And so many important pieces. So there's another question here that goes much more into detail about some of your research. And so I want to ask it because it's about the mosquito coils and the pesticides that you identified. So one is a very specific. Did you check the pollutants in the coils or in the smoke? And then the second part is what types of interventions came from that work, or how to deal with the pollutants that you uncovered?
In the coil. So we did not do indoor air measurements. although everybody should know that actually the indoor air is more contaminated than the outdoor air when it comes to environmental chemicals. So we did not do it. We analyzed the coil itself. And the second question was?
Interventions associated with that.
Interventions, yes. Actually, we, and that was one of the few policy victories. When I first went into environmental policy as part of my career, my then supervisor warned me that is the most boring of parts of environmental health that I want to do. Am I sure I wanted to do that? I was sure, and it's so important today when you see that so many policies in the past have been turned back to pollute more and to put people at risk more. So hopefully we will make those happen, but it takes a long time to do that. But specifically intervention, we actually halted that 500,000, those 500,000 mosquito costs to come onshore. We stopped the import.
That's fantastic. That's a real intervention, right? So I love that. I myself lived in Thailand for a number of years, and those mosquito coils really remind me of like that time and being home. And so when I smell them, it's like smelling someone's, perfume that I love or something. It's just, it's a comforting. So it was interesting to learn that maybe they're not all good.
I'm okay with them. I used to light the cigarette of my father with those. So I yes.
It's a complicated relationship. So there is a question here asking about if you know of any work that's being done in Russia. So the student has a Russian ancestry and thinks it would be interesting to explore that. I don't know if you yourself have done any. I know there's a Department of Russian Studies here at Pitt that would be good to explore. I don't know if you can comment on that a little bit.
I have not done so myself, although we had at Tulane in the department that I was in, as was chairing, several Eastern European scientists who came sometimes for 6 weeks, but sometimes for 6 months to be part of their dissertation research and collaborative opportunities. I very much am interested in spreading our collaborations across that part of our world as well. I think we're one world, and the more we do together, I think the more we can solve together.
Yeah, the woman, and I'm forgetting her name right now, but she was an interim director of our University Center for International Studies, is a Russian film professor. So a very specific area, but lots of engaged work in that region. So that would be a great contact. All right, there are no more questions in the chat, but I want to encourage people, there's one, good, to ask anything else. We have about 4 more minutes. So if you come up with a question, please post it there. In the meantime, I'll go through this one. So the comment is, we'll be starting an interdisciplinary street medicine student group shortly. Do you see the school taking more interest in the health of rough sleepers?
Thank you for asking that question. One of my other kind of somewhat surprises is that as a school, we're not more on the front line. And so I've committed our school to be very involved in the new community engagement center that the university is putting together in the Hill District. And actually, one of my MD PhD students at Tulane, and I need to check on whether she's graduating. I need to check on her. Thank you for reminding me of that. Is doing street medicine, and but one of the things that New Orleans and Tulane have learned after Hurricane Katrina, that there is no such thing as a silo discipline, or silo discipline research, or silo practice. And so there in community health centers, medical students, social work students, pharmacy students, nursing students, all with public health practice students, all learn together. And so that's how we're going to address some of the entrenched issues that are involved with street medicine. Homelessness is a crisis. And we're not going to deal with it in a silo way.
Yeah, that's a really important topic, and I'm glad to see us moving towards more direct community engagement on all of these really difficult issues that need to be, partnered approached. So one last question here, I think, and then we'll probably wrap it up because I know you have a lot to say on this topic, is to talk a little bit more about the Bachelor of Public Health program. So you have experience at Tulane. If you could share a little bit about the growth of that program and then what you expect we'll be able to do here at Pitt.
So let me begin with the end. Apparently there is the kind of the notion out on the street that this woman is crazy to start this in this fall, but everybody's excited to be on board. So what does that, the Bachelor's of Science of Public Health, look like? It is the best pipeline of scientists at the junior, at the bachelor's level that can make a difference, not only in education, but in community. So I'm a firm believer of that it will be a win-win-win for all of us. Unlike many other bachelor's programs, we will start we will start in the junior and senior year this fall, but next fall it will be a full first year admitting program. And so master students and PhD students are critical to be mentors as the Bachelor's of Science students begin to join us in their junior year. And so the design is that there will be three tiers of courses. The first tier is what is public health and what does the cell look like. The second tier is the epi-biostats and environmental health, not at the level and to the degree that master students are involved in those core courses, but that foundation as well. The third part is where master's and PhD students can be so instrumental. And that is, these are five specific courses that are elective and called specialty track courses that will feed into each of our 7 departments. So there would be 5 courses going into genetics and behavioral health and environmental health and in epi and et cetera. Doing that provides us an opportunity to engage students earlier and earlier in their career in public health. And that helping people doesn't only mean becoming a physician. And so the BSPH, MPH degree, the combined degree, will be an integral part of the BSPH program, so to speak. And then, as I mentioned earlier, we will be reaching out as part of our community engagement to public high schools here to begin to engage juniors and seniors in high school and creating a pipeline, particularly for minority and disadvantaged students into the BSPH. We will also be doing a lot more with our community college transfer students in the junior and senior year, as well as our regional campuses and our colleagues, practitioners in local and state and other health departments to formalize their knowledge. And so the Bachelor of Science of Public Health program would be critical. There's a question there that I see is, how would the career look like? It's very interesting where the BSPHs end up. A good portion ends up continuing into the masters and sometimes going into the MD and the MD-MPH program. I have a couple of students that I left at Tulane that were going into their PhD student, and I'm still mentoring them. But a good bit goes straight into practice, either in companies or from disaster management companies to insurance companies, in the public sector, so in local and state health departments. And so it really depends on what the discipline is that they're going into. But many catch that bug that's called further studies. And so they join us in the master's and PhD, and we love that.
So I know we could talk for a very long time about the undergraduate program and your experience and your plans. Sadly, we are past our time. So there are a couple remaining questions in the chat, but we promise to get back to everyone who has answered something or asked something that has gone unanswered. We'll email you directly. I just want to say a big thank you to you for joining us here today and for joining the school, and to all the students for attending and sharing your thoughts and ideas. We would love to hear from you about the undergraduate program. I know we have many students who come here with an undergraduate in public health from another institution. And so if you have particular insights, we would love to hear from you about what it would look like for our school. So I'm going to wrap it up for the evening.
And one more thing.
Yes, please.
So if you're here for your master's, and I am not neglecting our master's program. And so other thoughts that are not immediate, but soon immediate, I don't know how else to say it, is an MPH in pandemic science and an MPH and a broader MPH in health equity. So be thinking about that and how we're going to work with Dr. Burke and her team to materialize those. But we are really serious in addressing those and those that are of highest threat. So I'm delighted to be here. I'm thinking of last thing. I'm thinking of some kind of award, and that award might not be monetary, but that award be to shadow me for a day or a week or so, if you're interested.
So thank you all again. Thank you, Dean Lichtveld, so much for joining us, and have a great evening, everybody.
I love it. Thank you so much. Bye-bye.